Hello, my name is Nicholas Todd. Today we'll be discussing medial column headaches. We're going to be discussing our isolated soft tissue procedures enough to maintain correction. Disclosures, I am a consultant for Arthrex. So what we'll be covering today are soft tissue procedures of the medial column. The medial column is interesting because historically speaking, we've often talked about fusion of the medial column to address certain deformities. And we're going to address these deformities, but also ask ourselves, is it possible to correct some of these deformities without soft tissue procedures? More importantly, in this lecture, we're going to be discussing the soft tissue procedures for posterior tibial tendon transfers, spring ligament repair, and deltoid repairs. And do they work? And is it possible to have just soft tissue correction for medial column pathology? So when we talk about flat foot, what is the adult acquired flat foot? It's a collapsing pes plano valgus. What it is it's a dorsolateral peritalar subluxation. The foot dorsiflexes and everse around a relatively fixed talus, and you can see that clinically on the picture below. Most often, it's driven by compensatory biomechanics, such as a contracture of the posterior muscle group, gastroc equinus, and oftentimes with obesity. A lot of the times we see progressive deformity of the medial column with arthrosis. As the continuum of pathology, we start to see progressive instability in the static supporting structures of the foot and eventual loss of function of the posterior tibial tendon. Joints become more unstable, adapt, and rigid and arthritic. This creates a basis of our modern day classification system. When we look at this, can we interrupt this pathology when it's just a soft tissue aspect? Or do we catch this pathology a little bit too late? And that's what leads us down the fusion pathway. And so what we start to see is, what is the true pathology of the flat foot? So why do some flat feet hurt and others do not? Well, this is really interesting, and this can be a lecture on its own, but you have to look at if the foot is stable versus collapsed, if there's equinus. And Harris Beath in 1948 saw with World War II recruits, with flat feet, the symptomatic flat feet were associated with a tight contracture of the triceps surae. So surgical evolution of the flat foot is really interesting. Miller in 1927 saw the flat foot and attenuation of the medial soft tissue structures leads to a progressive deformity, he wrote. And this was in JBJS. And what his idea was to stabilize the medial column with a navicular cuneiform fusion, tarsal metatarsal fusion, and a PT advancement. A lot of those same procedures are done today, and I do them as well in my practice because it's tried and true, and it gives you a stable platform to walk on for the patient. Hoke in 1931, an operation of the correction of extremely relaxed flat feet, believed that equinus was significant. So this was a paradigm shift. He believed in the NC fusion, spring ligament repair, as well as a tendo-Achilles lengthening. So he saw not only what was happening to the arthritic foot, but what was causing it and catching it during and understanding what the actual pathology was. So what is the posterior tibial tendon? We often think that the posterior tibial tendon is the root of all evils with a lot of these dysfunction, and this is the major cause, and this is the only thing. Well, the PT tendon is the main dynamic stabilizer of the rear foot. Despite the important role of the posterior tibial tendon, it is the static structures. And I want to focus in on those, and that's what we need to look at in the repair. It's the static structures of the arch that provide most of the support. What's interesting is that it's impossible to create a flat foot model without sectioning the static supporting structures, such as the plantar ligaments and the spring ligament. This is extremely important because a lot of the times you can't just do a posterior tibial tendon repair and expect for the pain and disability to go away, because it's a lot of the other structures that have pathology and that have caused that flat foot. So again, posterior tibial tendon is remarkably strong and resilient. It deteriorates with deformity, attenuation of the spring ligament and plantar ligaments. So we really don't know what causes the deformity. Is this the posterior tibial tendon a late consequence of the deformity? And I'm not going to get into that, but understanding that the posterior tibial tendon is not always the issue. So what do we know about the flat foot deformity? We understand functional uncoupling. We understand the mid-tarsal joint and how it works with its So we understand functional uncoupling. We understand how the mid-tarsal joint works, and it's well understood. We know the first ray and the navicular cuneiform joint influence and how often there is technically a fault at the navicular cuneiform joint with pes planovalgus deformities. But let's look at the static structures, the spring ligaments and the plantar ligaments. What are the dynamic structures? This is something that's often not seen, is the posterior tibial tendon, the peroneus longus, and the plantar fascia. So again, focusing in on the entire flat foot, looking at it globally, not just looking at the posterior tibial tendon. The posterior tibial tendon, most of the time, is a late consequence. So we need to address more than just the posterior tibial tendon. And how we look at it in terms of soft tissue, does it need to be coupled with another soft tissue surgery, or is it always done with some type of osseous work? Well, let's get into soft tissue procedures. So when do we do an isolated soft tissue procedure on the medial column? When, again, isolated tendon pathology and it has to be a structurally stable foot. It has to be a balanced foot, but you have to understand that most of the times it will not work if you have a deforming force or you have other soft tissue structures that are compromised. So we also understand that soft tissue procedures assist in the stability and strength, and understanding the stability and strength are only going to aid our osseous repairs. So is there a mixture between, or is it one or the other? So looking at the flexor digitorum longus tendon transfer, this has been the workhorse for numerous years. It's a very powerful procedure when done correctly. It's a simple harvest. It can be done from a medial utility incision where you can easily locate the posterior tibial tendon and located very in close proximity is the flexor digitorum longus. In isolating this can be transferred either in a side-to-side fashion or it can be transferred into the navicular itself. A lot of the times the posterior tibial tendon has pathology, has a lot of synovitis surrounding it. It can be irritated and have multiple tears. The ways that we have to repair it again are a simple side-to-side transfer, or you can do a biotenodesis technique into the navicular. There is also some current thinking that releasing of the posterior tibial tendon and removing a section of this and transferring the flexor digitorum longus into the navicular tuberosity will remove the inflammatory force that the posterior tibial tendon has, because a lot of times it is inflamed or torn. So many people are starting to do this and thinking that there will be hypertrophy of the flexor digitorum longus and giving you a stable platform for the patient to walk, and recreating the posterior tibial tendon or what the posterior tibial tendon can accomplish. So again, you have many different ways of doing a flexor digitorum longus tendon transfer, but again, it's extremely powerful to recreate that degenerative tendon and to allow it to perform properly. So in terms of spring ligament, again, looking at the importance of the spring ligament, this is one of the structures associated with a flat foot deformity. And this can be, there have been numerous studies saying that this can be the result, one of the causes to have a painful flat foot. Again, this is the primary restraint to the talonavicular joint and prevents the subluxation that we all start to see. So this subluxation can start to occur, and this is where you can start to see pain around the posterior tibial tendon. And this can be identified as well as on the right-hand side, you can see identification of an attenuated or torn spring ligament. So how do we repair the spring ligament? Well, this has been complicated over the past couple of years because it used to be believed that simple suture technique could be utilized to repair the spring ligament. Well, we found this to be unreliable at best, and there have been new techniques, and we'll get into some of these. But if you could do a spring ligament repair, which corrects that TN subluxation, along with FDL transfer, which does alleviate some of the posterior tibial tendon pathology, is this able to correct some of the complex pathology? Well, an interesting study came out by Jorge Acevedo and Anand Vora from Miami. And what they found was that a combination of a flexor digitorum longus tendon transfer with a fiber tape repair recreating the spring ligament was the most reliable way of repairing the spring ligament and allowing the surgeon not to sacrifice any medial column joints, meaning that he did not have to fuse the navicular cuneiform, a lapidus, or a talonavicular fusion. And with his stage 2B Meyerson's staging of these flatfoot, they were allowed to salvage a lot of these feet without doing any type of fusion. Now, this did not mean that it was not uncoupled with a calcaneal osteotomy, such as an Evans or a medial displacement osteotomy. What they did find was that they were able to recreate the spring ligament, prevent that peritalar subluxation, and allow for correction of that attenuated or torn posterior tibial tendon with the flexor digitorum longus tendon transfer. And the way they did this, again, was using a biotenadesa screw with a spring ligament repair, having fiber tape from the sustentaculum carried into the navicular with the FDL tendon transfer. And this is an interesting article to read, and they published extensively on this, and they've done hundreds of flat feet with this technique. But what they did see was that they were able to spare the medial column with using soft tissue procedures. The one caveat being is with this type of fiber tape, there have been instances where you can over tighten the spring ligament and cause certain impingement, as well as decreasing mobility of that of the TN and causing pain. So they've had to adjust how tight they make that fiber tape repair. But again, this goes to show you that modern techniques have allowed for us to treat very difficult pathology utilizing soft tissue on the medial side. So we're now going to discuss about the deltoid and how the deltoid is extremely important, in not only anatomically, but in terms of some of our late stage flat foot repairs. And the deltoid is starting to get more press, not only in ankle fractures, but again, in these late stage flat feet that we're starting to see. But to fully understand and to understand how to repair the deltoid, we must understand the anatomy. So you have to understand that it has a superficial and deep component. The superficial component consists of the tibio-navicular, tibio-talar, and tibio-calcaneal. The deep component consists of an anterior and posterior tibio-talar. Again, this is a static stabilizer of the hindfoot, and it fails to gather as an envelope with the joint capsule. So I think this is an extremely interesting anatomic study, and this was done by Canton and his colleagues out of Vail. And what I want to show here is we're going to go through a little bit more of the anatomy, but what they showed is what does the superficial and the deep deltoid do? And I want to read this to you, that specifically the superficial deltoid resists eversion of the hindfoot, and the deep deltoid is primarily restrained to external rotation of the talus. So it's really interesting. But to repair it, we must repair both the superficial and the deep. So again, understanding the surgical biomechanics coupled with the anatomy is paramount to understanding how to repair it. Again, it gives you the resistance, that tibio-talar, that valgus tilt, again, for our late stage flat feet that we see, and it has, again, different components. So what are the clinical findings? Again, we're starting to see some subfibular impingement. We do see fibular stress fractures, sinus tarsi pain, subtalar subluxation, and talar head callus. So surgical reconstruction, this is really interesting. Primary and direct repair, advancement techniques, free tendon allografts, and you have to look at the patient in total, what the BMI of the patient is, what their level of activity is. What I can tell you is advancement techniques in my hands have not provided to be very, very useful. Free tendon graft has failed in a lot of circumstances because of the creep that you see with the tendon graft. And I've started to more focus in on my primary and direct repairs. At the same time, understanding that it's paramount to repair the superficial and deep deltoid. So what's the ideal deltoid reconstruction? Again, it has to be that you have to understand the anatomy, the anatomic origin, the insertion of both the superficial and deep bundles. You have to have a minimal graft preparation time, because you don't understanding that the graft can fail, or if you have graft creep, then you're going to have complete failure. And you're going to have secure fixation in bone to allow for early motion. So this here is as a direct repair, and you can see not only finding the medial aspect of the ankle, but also understanding into the subsentaculum to repair that superficial deltoid. So again, this came out of Clanton's article, but on the left-hand side, you can see the superficial fibers to the deep deltoid. And on the right-hand side, you can see the deep fibers of the deltoid. And a lot of the times you have to incorporate both of these to get a good repair to correct the soft tissue aspect. And if you are correcting for a late stage flat foot, you have to correct both of these, otherwise you're bound to have reoccurrence. So soft tissue procedures, and wrapping this up, I want everybody to understand that they're very powerful for difficult pathologies. And we focused a lot on the medial column, and they can be utilized anywhere on the foot. But they're always adjunctive if there's any deformity. In my hands and in the literature, you will have failure if you don't address the bony component and you don't balance the foot. So again, it's always adjunctive if there's any deformity. It's very powerful, but it has to be coupled with something else. Tendon repair and augmentation, understanding what the tendon does, the phases that it does fire is extremely important, and understanding when to do it and when not to, understanding the FBL tendon transfer, the principles of a tendon transfer, and grading the strength beforehand, extremely important in a preoperative setting. Looking at the posterior tibial tendon, understanding by itself, it's very powerful, but that's not the only thing, especially with these complex flat feet. Looking at the spring ligament and looking at ways to repair the spring ligament coupled with the posterior tibial tendon, are we now able to do more powerful procedures on the medial column, these soft tissue, powerful medial column procedures to avoid any type of fusion? And the literature is starting to bear out that we are, but it is coupled with joint sparing procedures more in the hind foot as well with calcaneal osteotomy. So it can't be done as an isolated soft tissue procedure. I also want people to remember that with these complex flat feet, you do have to look at if there's a gastroc equinus, because this is a very powerful deforming force and it has to be addressed. And if it's not addressed, you have to understand what needs to be done differently in the surgical procedure. So again, correct the pain and deformity while attempting to preserve a normal foot motion as possible. And again, with newer techniques, we're able to do this, and we're seeing this on the medial column. Want to create a neutral hind foot and a medial column buttress. And if you looked at Vora's and Acevedo's article, what they did is they did address that hind foot aspect, and they did create a neutral hind foot. The combination of a soft tissue balancing, osteotomies, and non-essential fusions, if possible. Try to stay away from fusing essential joints, as Sick Hansen said, the subtalar joint, talonavicular joint. Try to salvage as many of those medial column joints as possible, thus preventing further arthrosis proximally. Thank you very much.